Hi, Professor. Good evening.
Good evening.
How's it going there in New York?
Wonderful and very warm, beautiful. The city is opening up finally.
Oh, great. Great news. Great news. Excellent. So today we're going to have a conversation about oral minoxidil, especially about adverse effects. There is a growing interest of oral minoxidil for hair disorders. How often, Professor, do you prescribe oral minoxidil in your practice?
A lot. Many people get it. It's almost routine now in both men and women. It's very common to use now.
Yeah, it's very common. It's a routine, but I believe that still many clinicians are a little bit afraid of using oral minoxidil due to side effects. So we're going to talk about that. I will just share some slides just to start conversation. Let me try if I can show it to you. It's loading. Just a second. Okay, it's taking some time to upload the slides. Okay, now it's okay. So, Professor, I will show some recent studies published in JAAS. This first one is a revision of some previous studies showing, talking now, of course, about side effects. About 20% of patients presenting hypertrichosis. Of course, that depends on the dose, but it's the most common side effect. We're going to talk about lower limb edema, hypotension. They are not common, but sometimes some patients may present this kind of side effects. In the next slide, there is a multicentric study, and you were one of the co-authors of the study, and it evaluated about 1,400 patients, and 80% of them did not present any kind of adverse effect. It's the next one. Probably some problem with the slides. And in the last one, yes, for some reason, it's not working in our presentation. Now, yes, we are in the second slide. So here, showing that this multicentric study with 1,400 patients, 80% of them with no side effects. And among the 20% with side effects, 15% of hypertrichosis and other side effects like edema, headache, around 5% putting all of these side effects together. The next one, please, the next slide. And finally, other study, this one is from our group here in Brazil. We evaluated about 400 patients, and about 50% of patients perceived some hypertrichosis, but it was very subtle. I believe that we do not need to be afraid of this number, because we directly asked patients about, did you perceive any increase of hair in your forehead, in your cheek, in your body, in your arms? And half of them perceived some intensity of hypertrichosis, but generally very mild, and it wasn't a problem. Interestingly, we asked about hair shedding. Frequently, clinicians ask me about hair shedding, if it's a problem or not. And in this study, about 30% of patients perceived hair shedding at the beginning of the treatment, but with no major problems with hair shedding. Interestingly, we had 5 patients with very intense edema, including the face. It's uncommon, but we had 5 patients in this group of 400. So we must be aware about some more intense adverse effects. So that's it. We had some problems with our slides, but it's just for starting conversation. So, Professor, which dose generally you start using oral minoxidil in men and women, and how do you advise patients about adverse effects in the first appointment?
Okay, first of all, women are different than men, and it also depends whether you're dealing with a very small woman versus a larger woman. So I adjust the dose based on the weight of the individual or how big they are. So for a small woman, who's, let's say, 5 feet tall. I don't know what that is in meters, but someone who's small, okay, I do 0.625 milligrams a day. The reason I do 0.625 is the pills in the United States come in 2.5. So I tell them to cut it into quarters, and they take a quarter tab a day. And we do that for a few months. And if everything's okay, we can then increase the dose. But that's how I usually start a smaller woman. A larger woman who's, let's say, 5'10", okay, and I may start on 1.25 milligrams per day. And then again, they try it out. Let's see, some will not tolerate the hypertrichosis, all the side effects that can occur that you've already gone over. And I'll talk to you how I tell the patient that in a moment. And so it all depends on how they tolerate it. We may go to a lower dose or a higher dose, but I have put women even on 2.5 milligrams, a full tablet. And for men, it's the same situation, except I usually don't give 0.625. I'll start at 1.25, go to 2.5, and then go to 5. Now, low dose oral minoxidil is defined as anything less than 5 milligrams or less. So if you're giving 10, sometimes we may go to 10, but it's very rare. I hardly ever use 10. It would have to be a very big individual. But that's the rule of thumb that I use, whether I'm dealing with a man or a woman and how heavy they are, how big they are. And then I can decide on the dose that I will use. When it comes to side effects, I have from that paper that was published, the first author was Sergio Vano. We also helped contribute to it as well. There's a wonderful diagram in there that's colored that goes effects very nicely. And so it's really easy for the patient to understand. So I give them a copy of this particular diagram, and I'll either email it to them or give them a copy, and then we go over the side effects, each of them. And there's such a low chance that someone is going to stop the medication because of a side effect. Usually, if you readjust the dose, then they can tolerate it. But there's a small number who can't, and then they have to stop it. It's not a candidate for them. Especially if there's a lot of periorbital swelling and you just can't get that, you can't get rid of it even if when they're on lower doses. So there's certain conditions where they can't tolerate it. But for most people, it's not a problem, and I will put them on the oral dose based on whether male, female, the size of the individual, and I go through the side effects. Many will not accept a 15.1% chance of hypertrichosis. Some don't care. It depends on the patient. And but I go through every single side effect that's in that paper. Now, there may be other side effects in other papers, but that's the simplest one because it's so well designed. Okay, so I go through it like that.
Yes, great. And it's interesting, as you said, about increasing the dose gradually, because we know that some side effects like tachycardia probably will happen in the first hours, or edema or headache in the first weeks, or hypertrichosis even in 3 months. So probably if in the first 3 months the patients didn't present any kind of adverse effect, you feel safe and secure to increase the dose. So you do not need to wait, I don't know, 4 to 6 months, that's the time that we wait to see clinical results. So you can increase the dose previously.
There's a good timeline in that paper and that diagram that goes through what to expect in 1 day, in 1 week, 3 months. And I go through that timeline as well.
Yes, great. In fact, we presented the timeline, but unfortunately the slides were too slow, so we couldn't keep showing. But we presented at the beginning of our conversation this specific slide, Professor. And in which situations you do not prescribe oral minoxidil, or you prefer maybe topical minoxidil, or what kind of patients, in your opinion, are not good candidates for oral minoxidil?
If they have a cardiac history.
Yeah.
I mean, there are reports of pericarditis and all sorts of funny things that can occur. So if somebody has a history of tachycardia, palpitations, has a problem of irregular heartbeat, then I would avoid them. I would, however, have them ask their cardiologist whether it's okay to put them on low-dose oral minoxidil. But we have to get clearance from a cardiologist before we put anybody who has those kinds of symptoms, who has heart problems, who's had a heart attack, okay, who has all sorts of coronary artery disease. You have to be careful. That's why you need a good cardiac history. If there's no cardiac history, no problem. If there is a cardiac history, then they should get some kind of permission from their cardiologist to allow us to use it. And if they say no, then we say, okay, can we try the topical? We still need their permission, just use topical, because topical can sometimes cause tachycardia too, although it's very rare.
And Professor, have you ever had a patient with a very intense adverse effect with oral minoxidil, a major problem with the medication?
Yes, I have. I've had one patient who had major problems with tingling going down her left hand. We also had some kind of tightness she had, and we're all worried that she had some kind of heart attack. But when she went to the emergency and had EKG and had her cardiac enzymes done, it wasn't a heart attack at all. Okay, but I have had someone who did, who mimicked almost a heart attack. And so, of course, we stopped it immediately. And she had tingling in her fingers for a few weeks. So anyway, I've never put her back on it, of course. And we just use the topical, and that seems to be enough.
Yeah. And how often do you associate topical and oral? And in your perception, side effects, probably hypertrichosis will be more intense, but how frequent is this association? And about side effects, do you see a problem in associate?
When you say association, you mean using the two together?
Together at the same time.
Oh,
yeah.
I routinely use the two together.
Yeah,
Actually,
okay,
unless
like
somebody doesn't want to put something on their head. There are many women who just go to the hairdresser once a week and they don't want any kind of lotion. So you don't give them topical minoxidil. Or there are certain ethnic groups that don't want to put anything on their scalp because it makes their hair more frizzy. So we just would use oral then. But otherwise, I put them on both. The topical 5% minoxidil solution. Sometimes we use the foam, but I prefer the solution because it's easier for them to put on. It's more metered, I feel, and much of the lotion ends up on the scalp, not on the hair. And the foam ends up on the hair many times, but it is less irritating. So, so most people go on the lotion and the pills, and then I may add an anti-androgen in the mix as well.
And talking about anti-androgens, spironolactone, do you believe it's a problem because it's a diuretic? And sometimes we try to use higher doses, up to 100 milligrams per day. So how do you do this association with spironolactone?
Okay, well, there was a paper already published by Rodney Sinclair where he just used 25 milligrams of spironolactone with the minoxidil. But 25 milligrams of spironolactone doesn't really do much to grow hair. Okay, even though in this study it was a combination and they did grow hair. I do combine the two. I will use a lower dose of spironolactone instead of my usual 50 milligrams. I use it twice a day. I would go to, let's say, 25 milligrams once a day, see how they're doing. If it's okay, then we'll go to twice a day. And if that's okay, then we may go to 50 milligrams twice a day. So I haven't had much problem with low blood pressure or anything like that, but one has to be cognizant and warn the patient that this could be a problem. But I do start on lower doses of spironolactone because both are can affect the blood pressure.
Yes, yes. At the beginning, and because I said that this paper from Professor Rodney Sinclair associating very low dose of both. But I have some patients using 1 milligram associated to 100 milligrams of spironolactone with no problems. But I really try to increase gradually to avoid major problems. But I believe that most patients can really use both medications at the same time with no problem. Yes. And other associations, Professor, with dutasteride or finasteride associated to minoxidil?
No, I don't have a problem. There are 3 antiandrogens that we use. Actually, there are 4. There's spironolactone, which we've discussed. There's finasteride. There's dutasteride, and there's bicalutamide. Okay, and I present all the side effects of all of these things with the patient, and we decide on which antiandrogen we're going to use, type of thing. Now, certain ones you only use in women, of course, the finasteride, dutasteride you can use in both. So have to be careful about pregnancy and all that. So you go. I definitely frequently mix it with a antiandrogen. The problem now with antiandrogens, there's a lot of press now going that it causes depression, that it causes suicidal ideation, although it's extremely rare. I have had patients have sexual problems, but it almost always goes away when you stop the medication, although there are some people who feel there's something, that there's post-finasteride type of syndrome. I haven't seen it in my practice. However, there are cases out there that, we warn the patient about. But in terms of minoxidil, mixing it with any of these, I have no problem.
And do you sometimes use topical finasteride due to the fear of adverse effects of oral finasteride? So kind of switching oral minoxidil associated to topical finasteride instead of oral finasteride and topical minoxidil. It's a strategy for you, Professor. Do you use topical finasteride sometimes?
I think it's a good idea, but unfortunately in the United States, we're really not allowed to do that. Okay, so we have to be very careful here in the United States. It's not FDA approved. If you're using it in definitely if you're using it in a woman, you're not going to really want to use that. And in a man, if a pregnant woman touches his head. So in the United States, there's some issues. I have no problem with it. There are products out there already with some finasteride in them, and I will sometimes use it, but it's a bit tricky if we start using it too much. It's very popular in Brazil and it's very popular in Europe to use it, but in the United States, there's some issues whether you should be using it topically.
Yes, and talking about differences among countries, you said that in the United States you have 2.5 milligrams of oral minoxidil. Unfortunately, we do not have, there is no such dose in Brazil, as far as I know, in many countries. So 10 milligrams is more common, so it's hard to split the tablet. So we need to use compounding pharmacies. And so here in Brazil, we have to use compounding pharmacies for oral minoxidil all the time. And I believe that if we had 2.5 milligrams, it would be extremely easy to manage, to halve the medication, half the tablet as you do in America. And Professor, about hypertrichosis, we talked that's the most common side effect. It seems to me that depending on the country, culturally, some women will accept more or less. It seems to me that here in Brazil is not a huge problem. And like an example, a patient that I have that was using 1 milligram of oral minoxidil for 6 months, didn't get any result. So we increased to 2 milligrams. I consider a high dose for women. And she had a very good result, but with a very intense hypertrichosis. And I said to her, now we're going to have to decrease the dose. And she said, no way, doctor. I want my hair. We need to keep treatment and I will manage hypertrichosis in any way. Waxing is not a problem to me. So what's the situation? Did you have major problems with hypertrichosis? In general, patients accept hypertrichosis. It seems to me that it's not a huge problem as far as you explain for patients that it's common and that it may happen, but it's not a problem to manage. What do you think, Professor?
I tell patients if hair on your body, you can just imagine it's probably growing hair on your head too.
Yeah.
Okay. And there are depilatory creams. There are, waxing. There are all sorts of things people can do to take care of the hair. However, for some people, it's just unacceptable. And then we can readjust the dose of the minoxidil, but then you'll probably reduce the efficacy. Okay. And so you end up, choosing what's more important. I feel that most people will tolerate the hypertrichosis. Some will not. Even there are some men who will not as well.
Yeah.
There are many men who want to be hairless, and this changes their look. And so there are men like that as well. So we have to judge each patient, and if they decide that they want to stop it because of that side effect and they don't want to deal with using waxing or depilatory creams, then they don't use it. We try other options.
Yeah. Yeah. And that's important. Why is that important to explain for the patients in the first appointment? So sometimes you talk about hypertrichosis and the patient, oh my God, I hate body hair. So I believe that probably is not a good candidate for oral minoxidil, or maybe we can start in a very low dose and increase very gradually to not have this problem. So talking beforehand, it's a very good way to choose the best patient for the treatment. Professor, I believe that we are getting close to the end of our discussion. Do you like to add something maybe that we forgot? I will try to see if I can see some questions over here. Let me see, but if you like to, I don't know, mention something.
I think people should not be afraid of oral minoxidil. We've discussed already the side effects. It's become almost routine in my clinic to at least discuss it, and many people go on it. Okay, oral minoxidil is becoming almost standard treatment for androgenetic alopecia, and in men and women, and dermatologists shouldn't be so frightened of the side effects because it's such a low dose. And if they do get a side effect, it's very rare. And if they do, you can adjust the dose. So really, I think if you don't offer it to the patient, then you're doing a disservice.
Yes, great, Professor. And especially if we consider that androgenetic alopecia is a long-term treatment, and sometimes I feel that it's hard for patients to keep using topical minoxidil for long periods of time. And once the patient really adapts to oral minoxidil, it's easy to use, and patients can keep treatment, I don't know, for years and years. That's the idea of the treatment.
Yes. I mean,
yes.
Most things in dermatology, as we know, are forever. I mean, unless it's an infection where you have antibiotics or surgery and you can cut it out. Okay, most things are forever, not only in dermatology, but in medicine in general. Yes. So, I mean, if you have high cholesterol, you have to take something forever. If you have diabetes, it's something forever. So, when people say, do I have to take it forever? I said, in medicine, it's common to take something forever. That's the way it is. You've been genetically programmed to look a certain way. We cannot change the genes. We cannot cure the problem, but we can control the expression of the problem.
Yes, because of that, compliance is key for the long-term success of the treatment. Yes, perfect. That's great. Excellent, Professor. Thank you so much. Looking forward to seeing you in the next one. Bye, everybody. Thank you so much.
Bye. Bye-bye. Bye.